All right. Hi, everybody. My name is Brad Boynton. I'm a respiratory therapist at Mayo Clinic in our ALS center there. Um, Let me see here. Now, on my end, my screen just changed. You can still see my screen, I assume.
Yeah, we're good.
All right, good. So I got connected with the our ALS clinic a few years ago now. I am a respiratory therapist that has been working for this actually should say almost 28 years now. And I've worn many different hats in our department. I started working in our cystic fibrosis clinic back in 2014 with the outpatient type stuff. And then the nurse that I worked with at the time had a friend who was actually our ALS clinic nurse, and they were talking one night away from work, and the CF nurse Janelle was telling Carla, our ALS nurse, how she had a respiratory therapist that did all these things for her, and Carla said, "Well, I need a respiratory therapist." So that's how I got connected with the ALS clinic, and through my good friend Dr. Bernardo Salim, who's a pulmonologist here at Mayo. We got myself connected to working in the ALS clinic. So that's kind of how I got to the ALS clinic. But I also work in a whole bunch of other outpatient areas. I work in cystic fibrosis. I work in pediatric pulmonology. I work in pediatric aerodigestive, which is really just a fancy medical term for, complex medical kids, many of whom have tracheostomy tubes and are on ventilators at home. So that gives me a little bit of experience too. What happened with my trach experience is I worked in the pediatric and neonatal ICUs for a long time, for about 15 years actually. And we had many, children with tracheostomy tubes. And the way that our program here worked was we had nurse practitioners that all the education for trach and ventilator kiddos here at Mayo. And we came to work one day and found out that all the mid-level nurse practitioners were no longer in the ENT department. So it sort of left a void in our hospital here with what do we do with these pediatric patients who have a tracheostomy that wants to go home? And what you should know about pediatrics is that there are no institutions in the state of Minnesota that or very few that take pediatric patients with tracheostomy tubes. So our only option is to send them home. And so when we no longer had the nurse practitioners to do our education, we needed to figure out a way to set up a education program so these kids could go home. And at that time, I was actually the supervisor of the pediatric group, and myself and the one of the nurse education specialists in the pediatric ICU came up with a whole program of how we teach families to take care of trachs and then how we get them home. And because of that experience, I have a pretty good knowledge of what it takes to educate somebody on how to take care of a tracheostomy tube at home. And also, because when we set this program up, we had to work with our great people like our social workers here at Mayo. That helps us with the discharge process to get these patients home. So all this experience kind of, I guess, gives me the right to talk to you today about tracheostomy tubes. And so, I don't like to just sit here and talk. So please, if you have a question while I'm talking, or if you want to put something in the chat or raise your hand or however we do this, I think we're on Zoom, right? We can use the raise the hand function or whatever. If you want to do that, I'll try to answer your questions as we go. Otherwise, we can certainly answer some questions at the end because I think we will have time. Okay, and we should let everybody know that this is Mariah Kane's fault. She's the one that asked me to do this, so we can blame her if this isn't good, okay? I hope that's on the recording. She'll love me for that comment.
I'm going to send it directly to her after this.
Okay, good. So, tracheostomy in the face of ALS. these are heavy, difficult discussions, right? You know, this whole process of trying to decide if we're going to go forward with a tracheostomy is a very, very difficult one. My job today is to try to stay neutral. I don't want to, I don't feel like my job is to encourage you either way of whether or not you should get a tracheostomy tube or not. My job is to tell you what it's going to take. Okay. There's a lot of education that's involved. And then once you get home, you have to understand, in my opinion, what this is going to look like. So those are the things that we're going to talk about today. And the fact of the matter is, your ALS team should support you no matter what you decide. And you know, it's not just your ALS team. I believe that many other programs are set up just like ours, where we have palliative medicine, you know, hospice, all these different services available to us, social work, that help us make these decisions along with your ALS clinic team and your neurologist, right? Okay. So what in the world is a tracheostomy tube and how does it work? So this photograph here is taken right off the Mayo Clinic website. Okay, so that's where this little picture comes from. So you see the young man has this what looks like a piece of glass right on his neck there. That's the sort of the sagittal cut or the cut where it shows you the picture, you know, down here at the bottom. Okay, so I don't want to insult anyone's intelligence, but let's go over some anatomy, okay? So this little box right here, if you can see my cursor, this would be the chin here, okay? And this actually is, this right here is the tongue muscle, okay? And then you go down here and there's sort of, in the back of your throat, sort of, there's two tubes, okay? The one that sits in the front that looks like it has some little like ribs in here, that is your trachea. That's your windpipe. That will go down, and this is the windpipe right here and connects directly to both of your lungs, okay? The tube that sits in the back here, and oh, by the way, this tube, huge, big tube, okay? The tube that sits right behind it, right here, is your esophagus, okay? And that's important to know. So these two tubes sit one right in front of the other in your neck. And so you can see what happens in a tracheostomy tube. They make a surgical incision in your neck, and this tube fits through the surgical incision. And then the part that you see out here, this part right here with this little connector tube, that's this right here. And so the tube goes through your soft tissue and down into your trachea. And we're gonna talk about this little balloon and things here in a second, but this is how this works, okay? Then if you look up here, there's a little holder sometimes that, or not sometimes, but there's a little holder that holds this tracheostomy tube in place, okay? Many times this tracheostomy tube is sort of a two-part tube. It has this little inner canula that you can take out and clean, okay? So we'll talk about some of that stuff later too, but this is how the tracheostomy tube works, okay? This little balloon here at the end of this, there's another little piece that hangs on the outside of your chest that you can inflate and deflate this little balloon. And that's important because when we talk about hooking you up to a mechanical ventilator, that little, not always, but sometimes that little balloon has to be inflated, because you see that now instead of breathing through your nose and your mouth up here, and the air comes in and out through this through the trach tube and up through your nose and mouth, when you blow this balloon up and you connect the ventilator right here, then the ventilator breath comes in and out through this, okay? So we've completely bypassed your upper airway. And that's important to know, because when you bypass the upper airway, as you can see in the notes here, you bypass your nose, or your body's natural humidifier. Okay, and that's okay because most ventilators have a humidifier attached to it, or sometimes we can even put this little thing called an HME, a heat moisture exchanger, on the end of the trach tube or in the ventilator circuit itself that acts as a humidifier. Okay, but you should know that you're not going to naturally humidify the air you're breathing in and out if the air is going in and out through a tracheostomy tube. Okay, so you have to humidify the air. Not, it doesn't necessarily have to be 24 hours a day, but most of the time when you're sleeping, you will have a humidifier hooked up to you because we have to keep that gas that's comes in through the ventilator nice and humidified for you. Okay. The other thing you should know is that your thyroid cartilage, you know, your big old Adam's apple right here, that's where your vocal cords live. And so now this tracheostomy tube will sit below those vocal cords. Okay, so now when I speak, the way that the vocal cords work is they have to have air passing through them in order to make sound. So now we're going to bypass that too, okay? That's not to say that if you get a tracheostomy tube, you won't be able to make sound. You know, if you don't have you know, severe bulbar symptoms and you still want to be able to speak a little bit, if that's possible for you, then that's okay. We can use this little valve called a Passimir valve that goes in line with that ventilator, or sometimes just right on the end of that tracheostomy tube. And it's a very simple little one-way valve. And what that means is air will come in through the tracheostomy tube and inflate your lungs. But now when you go to exhale, that valve closes, so the air won't escape through the tracheostomy tube. This balloon has to be down when we use this thing because now the air comes in through the tracheostomy tube and will pass back up through the vocal cords, if that makes sense. Okay, so it's not a deal breaker if you get a tracheostomy tube and someone says you won't be able to talk anymore. It's sort of true, but we can get by that with using a Passimir valve. Okay. And you know, you could see that you could suction and you can use the ventilator and all that stuff too. Those are some of the benefits, but we'll get to that in a second. I just wanted to put this little slide in here to sort of give you a visual representation of what a tracheostomy tube will look like. And I reserved this room and I was going to have one to hold up for you. And I'm sorry, I forgot the darn thing. So sorry about that. Okay. Does anyone have any questions about how this works? All right, good. We'll kind of move on here. So now these are sort of just my opinions, okay? So what would be some of the benefits, you know, if your ALS team or your neurologist or your palliative care team or whoever said you might want to consider a trach and you're considering what would be some of the benefits? Well, you can see that, you know, when you have that sensation of you have this phlegm and it sits in the back of your throat and you can never kind of handle it. Now you just stick a catheter down this tracheostomy tube here and you suction right into your lungs directly. It's actually makes this whole process very, very easy. You can get rid of mucus and that sort of thing really, really easy. It will require you to have a home portable suction, but those are very easy to get from any local DME. And with a diagnosis of ALS, there should never be any trouble getting those paid for through an insurance company, okay? And when we talk about airway clearance and we talk about cough assist, you know, before your tracheostomy tube, if you're using cough assist to help you with your peak cough flow and your cough where you know, the cough assist helps you take a big deep breath in and then it physically helps you cough out. And many times you have to use the mask with that, right? Now you can actually hook the cough assist right up to the tracheostomy tube. So it'll help you take a big deep breath and then it'll physically help you cough out and move secretions forward. And if it doesn't come right out the tracheostomy tube, then you can just suction it right out at the tracheostomy tube. So all of these things are certainly a benefit. You no longer have to worry about trying to handle that mucus. Okay. The next one says no more non-invasive ventilation, or in other words, you no longer have to wear your BiPAP mask on your nose and your mouth, and then we get breakdown on our nose, and we get breakdown on our cheeks or whatever. Or you open your mouth and then the BiPAP, you know what I mean. If any of you are currently wearing BiPAP, you know what I'm talking about. But BiPAP is a great, great thing that helps us, clear CO2 and helps us breathe. But the fact of the matter is, BiPAP masks are designed for one size fits most. Mm-hmm. And they just don't always work the best for some people. So now you hook up your BiPAP or your ventilator right to your tracheostomy tube, and you no longer have any of the issues with the BiPAP masks. Okay. And honestly, studies show that it could or it may prolong your life. So those are certainly some benefits to tracheostomy tubes. All right. What are some of the challenges? Well, tracheostomy tubes and or mechanical ventilation certainly have a pretty high cost, and that can certainly be a challenge for some. If someone decides to go forward with a tracheostomy tube and or are on a mechanical ventilator, you likely will qualify for home nursing care. Okay, so that comes with some challenges, because at least in the state of Minnesota, the state of home nursing is very, very challenging. Before I stopped doing all the pediatric tracheostomy stuff and we were trying to send kids home, Minnesota, Wisconsin, Iowa, North and South Dakota were very difficult for home nursing. Very, very difficult. So despite the fact that you may qualify for home care nursing, it may be a challenge to get some home nursing. We already sort of talked about the communication piece where it may become a little bit more challenging for you to communicate. Now, sometimes folks will already have pretty severe bulbar symptoms, or their tongue and mouth muscles aren't cooperating. So the communication thing might not be a big a deal for some. But if there's those who want to go forward with a tracheostomy tube that don't have severe bulbar symptoms and still want to try to be able to communicate with with your voice, then we can do that, but just know that we have to go down the road of using the passing mirror valve. And then if there is that little balloon, on the tracheostomy tube like this, we have to make sure we educate people on how that balloon has to work when we have to use a passing mirror valve, because the balloon has to be down. It cannot be up. Okay. I put privacy on there because what you should know is that if you go forward with a tracheostomy tube, you will qualify for home nursing or home care of some kind. And this, can sort of become intrusive, right? Because the fact of the matter is, taking care of a tracheostomy tube cannot be done by one person, right? It takes a team of people. It takes a whole team of people, and it can be what we used to say with the pediatric patients, and I know, adults might be a little bit different, but with a pediatric patient, we had the attitude that this takes a team of 5 people. When you think about a 24-hour schedule, 24/7, 7 days a week, that is going to take a minimum of about 5 people to cover all that, right? Because with pediatric patients, sometimes we had mom and dad and then 2 nurses and an aunt or something that would help. You know what I mean? But with ALS, it may not take 5 people, but you should know that if you only have 2 nurses and a spouse, then you might want to think about there might be at least one more person that you need that's going to help with taking care of this tracheostomy tube, because it is, quite frankly, a lot of work. Your home, anytime anyone goes home with a tracheostomy tube, any durable medical equipment company that is going to put equipment in the room, like a ventilator that needs to have a plug-in to charge, a feeding tube, with a pump that needs to run, all these things that require power, your home has to pass a safety inspection. Or in other words, many times, if you have a home that still has an old fuse box, your home won't pass an inspection for you to go home with a tracheostomy tube. It has to have some sort of circuit breaker type system, and it has to have electrical output where it can handle high loads, because we're going to have things plugged in. Do you see what I mean? It has to pass the safety inspection as far as being able to get around the home if needed, and that sort of thing, with a wheelchair or whatever. So most home durable medical companies will require you to have a home safety inspection first, before we even talk about if we're going to be able to send you home with a tracheostomy tube and a ventilator and that sort of thing. All these things that we may send you home with, like a mechanical ventilator if you have a tracheostomy tube, or a feeding pump, all these things require power. Here in Minnesota, we have winters that sometimes can be tough, and we lose power. This winter wasn't terrible, but the weather I know in the Southeast this year has been very challenging, with a lot of severe weather. And so you have to sort of plan for if you're on a ventilator through your tracheostomy tube or a BiPAP, how much battery do I have? Right? The newer ventilators, like the ResMed Astro and those sort of things, have awesome battery life. And so it's not so much of an issue anymore, because most of these ventilators have a detachable battery that comes in and out that you can switch, and it also has an internal battery, like up to 9 hours of battery, honestly. So it isn't such a big of a deal. Some people ask, well, do I need to get a generator? And I'm in the camp that says, well, I don't know that you need to really get a generator if you're going to need to be on a mechanical ventilator, but you ought to have a plan, right? I know I have X amount of hours on a battery, and if I know that I'm not going to have power restored, I have to have a plan. I have to go to the closest local hospital that is going to be on backup generator power, and just show up and say, I'm just here because I need to plug in. I'm a ALS patient. I need to have my ventilator plugged in so I can recharge my batteries. Some people do get a marine type battery that they can plug things into to help recharge. There's many options, but the point is, you have to have a plan for loss of power. Okay. Now my slides froze up. There we go. All right. So having a trach at home, what does that look like? I think the first thing we need to talk about is families have to understand that taking care of a trach at home is a lot of work. And when I told you about the 5 caregivers or the 4 caregivers, or maybe sometimes you can get away with 3, it's going to take a lot of people to help you do this at home. Okay. And you have to have a good program to educate people how to do this. Our job as a respiratory therapist in our program was to teach people about emergencies. What happens if the trach comes out? What do? You have to know what to do if a trach comes out, because the fact of the matter is, if you call EMS and they show up at your house and they see the tracheostomy tube, they're going to be like, oh, I don't have a lot of experience with this. What they're going to want to do is just put that resuscitation bag and mask over you and cover your stoma where your trach tube was, and just ventilate you, because they don't want to deal with the tracheostomy tube. So the nurse, your nursing staff, and even sometimes family members and the spouse, in my opinion, should know what to do if the trach comes out. Okay. This DOPE mnemonic that I have here, where it says emergency procedures DOPE. DOPE is a mnemonic that helps us remember. We joke around with families and say, don't be a dope. You have to understand what DOPE means. We sort of take the P out because P stands for pneumothorax, and there's nothing you all can do at home for a pneumothorax. but D is displacement, or in other words, if it comes out, what do I do? And then O is occluded or obstructed. What do I do if the trach tube becomes plugged or occluded? And then E stands for equipment, or in other words, if the ventilator malfunctions, what do I do? Do you see what I mean? So we, in our programs here at Mayo, we teach people, what do you do if it becomes dislodged? Well, you get a new one and you put a new one back in. It's pretty simple, right? What do I do if it becomes plugged? Well, you have to change the trach tube. You have to take the plugged one out and put a new one in. Or some of these trach tubes will have this two-part system where there's an inner cannula that you can actually remove, but the trach tube stays in. You can take the inner cannula out and put a new inner cannula in. And then for equipment problems, you have to know what to do if there's equipment malfunctions, right? You know, we talked about that trach tube that has the balloon at the end. That can break, right? You have to know what to do if that breaks. Your ventilator can stop working. Hopefully not. These days, they usually don't do that. But you have to know what to do if that stops. So in our programs here, we teach people what to do in an emergency situation, okay? You also have to know what to do on a daily basis. These ties, you know, that hold this trach tube in, these things right here, they're made of cotton most of the time. The problem with this little Velcro cotton tie is Velcro is great when it works, and Velcro is not so great when it doesn't work, right? And when cotton gets wet, it stays wet, and then it causes skin breakdown. So you have to change these things every so often on a regular basis. This little surgical incision that's made in your neck called the stoma, that has to have care done to it every single day. We have to keep that clean. And again, so we don't get skin breakdown, right? Skin breakdown is bad because if you get skin breakdown underneath these ties or at the stoma site where the tracheostomy tube sits, that is so hard to get healed and so hard to get taken care of. So you have to take care of it every single day. All right. So those are some things for daily care that you have to do. The ventilator will have to be, you know, the whole circuit, or sometimes the part that hooks right to the tracheostomy tube. If you have enough power to cough, or you use the cough assist and it pulls junk up into the little connection that the ventilator tube has, well, you have to change it. Most of the time, ventilator circuits have to be changed at least monthly. So there's work and education that has to be done on that. And then the equipment care itself. You know, the ventilator has to have maintenance done every so many hours. Many of the newer ventilators today, they have 20,000 or 30,000 hour maintenance. So then your home care company has to bring you a different device and set it all up and take that one in so that it can have maintenance done on it. Okay, so all these things that you'll have to learn about if you have a tracheostomy at home. And we sort of already talked about the home nursing care, or the home, you know, nursing assistant, caregivers, whatever we want to call them. You know, some people find this a little intrusive. And like we already talked about, it's very difficult to find home nursing, right? Very, very difficult. And then nurses get sick. You think you have your week covered, and then someone gets sick, right? And now we don't have anybody to help cover with taking care of the tracheostomy and the ventilator. And then, you know, around here in Minnesota, at least, with all our large medical centers in the metro and, you know, Duluth and Rochester, RNs leave for better opportunities. So that's the reality. We already talked about this too. Family members may have to help. We trained one time two aunts and two sons and the husband to help take care of a young lady with ALS at home, because we couldn't find home nursing. We couldn't find any home care nursing agencies, and she didn't want to go to facilities, so she went home. Okay. There's actually a lot of resources out there. You know, you all have probably heard about some of these resources. The one that I want to point out is the one on the bottom. Dr. Sam Major, I'm not sure I'm saying that name correctly, at Hennepin County, along with one of the nurses from the ALSA. They made this great document that talks about all these things that we've sort of talked about today. Right, you know, they talk about what does it mean to have an invasive ventilator or a ventilator that's hooked up to a tracheostomy tube, and what are some of the challenges and that sort of thing. Just by looking at this document quickly, one thing I forgot to mention is that if you decide to go home with a tracheostomy tube, you'll have a ventilator. Some insurance companies, not many, but some will actually pay for 2 ventilators. Or in other words, now Medicare won't, I know that, but you'll have a ventilator that sits at your bedside that's set up for you to sleep on where the humidifier is hooked into it. And then there's one that you sort of keep on your wheelchair maybe, where that's more of a portable ventilator for you. Now, like I said, some insurance companies will pay for 2, many of them won't. But just know that you might be able to get 2 ventilators if you have a really good insurance. Medicare will not. I know that for sure. So there's a lot of good references out there for you. I just have some of these listed here. And you know, that's really kind of my whole overview of this tracheostomy mechanical ventilator. Oh, and we didn't even really talk about, you kind of have to, in my opinion, you kind of have to learn about the ventilator, right? You have to learn about if it's BiPAP settings or if it's AVAP settings or if it's the actual ventilator setting. And in my opinion, you got to kind of know what those settings mean, sort of, because if that ventilator alarms for a reason, then you should be able to troubleshoot it some, right? Now, your home care company hopefully will be good and will tell you, you know, only if it makes this alarm, should you contact us, or, you know, if it does this alarm, don't worry about it, but if it makes this alarm, then contact us. You know what I mean? So you should have a good relationship with your home durable medical company too. And I think that's about all I have. What questions does anybody have? How are we doing on time? Well, we have plenty of time for